Not getting your health and wellness questions answered at your doctor's office? Are you ready to take control of your health and well-being? Do you want the proper tools to set you on your wellness journey? Do you want to meet and chat with expert members of the healthcare team? Well, step into real time with Dr. Stacy. Hi. I'm Dr. Stacy, your personal physiotherapist and wellness consultant who wants to make sure that you live your best life. We'll be chatting with wellness team members and inviting you as you are the center of that team. And we'll be doing all of this while you are in the comfort of your own home or office. Join me in real time with Dr. Stacy as we discuss everything health and everything wellness. And good afternoon, everyone. A pleasure yet again to be with you in the comfort of your home and office on Real Time with Dr. Stacy. And I know it's been a tasking few days, but I'm so happy that all of you have stuck it out with me as we learn with each other how we can live well with diabetes and control and manage living with diabetes. It is not a death sentence. So just to remind us, we had our first speaker, Nurse Wendy Phillip, our diabetic educator, followed by Tracy Jackson, our dietitian, then Dr. Deborah Bartholomew, our eye specialist, and I'm so happy that we're having another guest today, Dr. Alleyne, physiotherapist and wound care specialist. So just as a reminder as to why we are doing this journey together, there are over 200,000 known persons living with diabetes in Trinidad and Tobago, in this very small Twin Isle Republic. And we must take control back. We have too many complications because of it, because persons are not knowledgeable in knowing how to deal with such a diagnosis. And that's why we're here. So we are helping others get well with diabetes. I have to give a personal shout to someone who I want to meet in flesh very soon, Miss Oma Singh. Oma has been here on every show but one, and that one show that she missed, she watched in its entirety on my Facebook page. So I want to say a very special welcome to Oma Singh and all the other viewers. There's still enough time for you to share this feed with your friends and your family, because this is information that you will not get very easily at your doctor's office or at a clinic, because sometimes there's just not enough time. So please take advantage of this opportunity that is being presented to you. So good night again, Oma, and to everybody else, please feel free to send your questions and message us as we continue during the show. And we will try to answer all your questions, if not tonight, but definitely over the next few weeks on my Facebook pages. All right, so don't be a stranger. Now, tonight I'm going to bring on our guest. I'm going to bring her on screen, and it's my greatest pleasure to welcome Dr. Verne Alleyne. Verne Alleyne is a great colleague of mine, and as I introduced on my video today, she's a physiotherapist par excellence. Even though she doesn't look it, she is a physiotherapist with over 26 years, about that experience. And not only is she a physiotherapist with experience working in Trinidad and Tobago, she has worked extensively in different parts of the United States. She's also the wound care coordinator of the first chronic wound management department in Tobago, a very much needed department that did not exist prior to Verne's vision. And her vision was actualized and providing excellent service for those with wounds, especially to the feet. Verne is a certified wound specialist from the American Academy of Wound Management. And I promised you all when I was inviting my guests that these would be persons who were not only experts in their field, but who have gone the extra mile to ensure that they provide service. They're providing a service. It's not for them. It's not for the fame or glory at all. I mean, when you think about wounds, what glory could there be? But because of her desire to help persons in Trinidad and Tobago, Verne has certified in wound care. And she will give us a little more information about herself. As I said, she doesn't look as her experience, but she is a wealth of information. Utilize tonight, please. So, on behalf of all of us, I would like to say a hearty welcome, Dr. Alleyne, to Real Time, Dr. Stacy.
Thank you. Thank you, Stacy. Thank you so much for having me. It is indeed a pleasure to be on this forum, to share and to help persons who are in the diabetic community or who have family members that they could pass on some information onto.
Yes.
So it's indeed a pleasure for me to be here.
Thank you so much. And just before we get into the meat of the matter, with regards to the role of exercise in the person living with diabetes, and of course in care of the feet and wound management, just give us an idea of how you ended up becoming a physio and deciding to specialize in this area, because there are so many other specialties in physiotherapy that have a lot of glamour, you know, like sports physio and orthopedic stuff. How did you end up here? It's such an interesting pathway for a physiotherapist.
I actually ended up in wound care quite by accident. When I was in the US, the part of physiotherapy was actually wound care. So whether we liked it or not, we had to do some element of wound care. The last hospital that I worked in was what was called a level 4 trauma hospital. And in that scenario, we saw a wide range of all sorts of conditions, and one of which was complex and chronic wounds. So when I moved to that department, I told my supervisor, I said, I'm an orthopedic therapist because orthopedic therapy is my first love. Orthopedic therapy and sports. My master's degree was concentrated on orthopedics and sports. So I said, I'm an orthopedic therapist. And she said, you're serving an indigent population. And once you work here, you have to treat wounds. So I fought it. I went to the secretary, the lady doing the schedule, and I said, don't put any wound patient on my schedule. Please don't. There are other people here who would like to do it. I don't want to. Don't do it. And every once in a while, I would get one and I would quarrel. And when I started doing my doctorate, I had to change my hours so that I can get time to go into the library down to the university. So I had to change my hours. And then I was forced to see way more wound care patients than I had to. But I have to tell you that prior to that, my father died from complications of a diabetic foot amputation. And at the time he died in 2001. When he died, I was not as much into it as I am now. What I can tell you is when I came home and I saw him, I saw some strange things, like they were washing his wound with seawater. And I was perplexed by that. I was like, why are you guys doing that? They said, the nurse and the doctor told me to do this. And I could not convince him that this was not the thing to do. And as statistics would have it, if you have a diabetic foot ulcer, chances are within 2 to 5 years, you will be dead. And 2 years later, he was dead. And when I sat and I saw how he moved from a toe amputation then to a transmit amputation.
Mm.
When I was coming home, I was like, okay, so you're a physio. We have many other physios here. What else can you do? And so I decided, well, I can do a little bit of wound care, not a whole lot. I will probably see 1 or 2 patients every year, 1 or 2, and I will help out 1 or 2 patients while I continue to see my
Mm-hmm.
orthopedic patients. And that was where it started. So I got my certification and I started a pilot project and realized that this 1 or 2 patient thing is not working out. The
Yes.
numbers of chronic ulcer patients that I was seeing was beyond my imagination. And then,
Yes.
so eventually I moved into doing wound care more than orthopedic in the public setting. And then after a while, I recognized that there was a big gap. So you heal the wounds, then what next? And there was
Yes.
I did not, I know what to do, but I wasn't qualified to do it. So I knew
Mm-hmm.
the patient needed special shoes, special orthotic, a special way to fit the shoes, a special
Yes.
orthotic to be made depending on the type of ulcer. So I decided to go on again and get certified in being a pedorthist, and that way at least I can
Yes.
make a professional judgment on what happens after the wound heals, because that's also a critical part in managing people with foot problems, with foot issues, and post ulcer.
Yes.
So I went into wound care kicking and screaming.
And yet you're still there. I think because you've realized the value. And if you did
Yeah.
not have that vision, there still may not have been anything like this in Tobago. And I'm hoping anybody listening out there, I'm hoping Andrew Danu, who is the president of the Diabetes Association, is hearing this, because this might be a fantastic project, Andrew, wherever you are, a fantastic project for the Diabetes Association to take up and maybe work with Verne. Verne, I'm putting you out there, at some point in time to form such a needed, dedicated unit in South and Central Trinidad, because there may be an East and probably not in North. So to have it in every corner of the island. The aim is not to just control the sugar. The aim is for people to live well, to be able to manage, preserve their
Correct.
eyesight, to preserve their limbs, not just to be alive and breathing and non-functional. So thank you, Verne, so much for your vision and for the service. And sometimes we go kicking and screaming into where we're going to have most value. And you have definitely done that. So thank you so much for that. So, ladies and
Thank
gentlemen,
you.
you all, I remind you again, all my speakers are persons who have done certain things, certain projects because of their love of humanity, and they're doing a service, not for themselves. So again, please, anytime, congratulate the speakers and Verne tonight for doing this. And we're going to head right on into tonight's hot topics. Now, just a little disclaimer. Verne's presentation will consist of some pictures because we're looking at the care of the feet. You may feel a bit uncomfortable with some of them. That's okay. We need you to see what ulcers are and to understand the healing process, etc. So don't be afraid, they're just pictures, but this is a reminder of where you don't want to end up, as well as if you have a family member or relative who is experiencing some sort of issue with ulcers, that you know where it can go and what you need to prevent. So I am going to hand over to Verne. You will see the beginning of her slide on the screen. And Verne, let me just say good night before you begin. Good night to Glenda Carty. Glenda seems to also be just like Omar, almost on every show. Good night to Sharon Hill, Saint Helena. Thank you all so much. I know I can't call all the names, but I'm calling those of you that I see on both my feeds. And please feel free to share this feed throughout the course of the evening, because this information, you will not get it easily anywhere else again. So, Dr. Verne Alleyne, the floor is yours.
Thank you very much. And so we'll move right into I'll divide the presentations into two parts. So we'll quickly talk about diabetes and exercise, and then we will spend some time talking about diabetic foot ulcers and diabetic feet, because believe it or not, it is very common in people with diabetes. And I think it's very critical to understand and to prevent diabetic foot complications. So we'll move right into the fact that diabetes, type 2 diabetes around the world is growing at alarming rates. And for you, those of you who would have heard prior presentations, this would have been echoed that the number of persons with diabetes worldwide is growing. And this, Trinidad and Tobago, is no exception. And sometimes I want to believe that we might even be growing at a faster rate than other more developed countries and regions in the world. And as I was putting the slides together, I said, you know what? And COVID-19 would have worsened the rate of growth of the diabetic epidemic that is being faced worldwide. And you may ask why. It's too basic. The reasons are simple. Two things that is occurring with our modern, and I like to say affluenza lifestyle. We are having decreased physical activities. If you sit and remember how active you were when you were a child, well, when I was a child, which was many, many years ago, when you used to walk to school, walk to and from school, go walk back home for lunch, and play on the way home from school, all those days are over. Now we have children, they are dropped off at the school door and they are picked up, and then they are taken into a house where they will just sit at the video games and at the computer, and no time for physical activity. And now with the advent of the global pandemic, additionally, we have children now just sitting all day long on the computer, and we're having little or no physical activity even from childhood. So the stage is set now from childhood right into adulthood. And remember, as children, we are definitely more active as children. And as we get older, we get less and less active. Well, the adults who are naturally less active than children, who would have normally taken a walk. We have short drop taxis now, so we don't we don't have to walk. I remember when I was working at Port of Spain General Hospital, I would walk from Port of Spain General Hospital down to Independence Square. The days for that are gone. Very few would want to do something like that. The sun too hot, and we find all kinds of excuse not to engage in physical activities. In Tobago, we have a situation where from uptown to downtown, you can no longer walk from uptown to downtown. Less than 400 meters, you take a taxi to be able to prevent you from walking. So our lifestyle and the increasing rates of obesity. So we're not active, and then we're getting bigger and bigger, and this is feeding into the diabetic epidemic. I remembered when I came back home in 2018, I said to one of my colleagues, when I went to the US in 1996, I remembered every once in a while I would see someone who was 400 pounds. Once in a while, and I would do a double take. I was like, oh my gosh, that person is 400 pounds. And every once in a while, I would see somebody 600 pounds. Well, at the end of 12 years, that was a normal occurrence. It every day you would see 10, 11, 12 people at 600 pounds. That was no longer a rare occurrence. The furniture in the hospitals had to change. We had to pay attention to the max load level. So in order to avoid litigation, we have to make sure that we have bariatric wheelchairs, bariatric bed, bariatric, all the furniture, bariatric bicycles, but we have to make sure that our weight capacity for all our furniture meets the standard for today. And I said to my colleagues, I said, what I saw in 1996, I bet you in a couple of years, we'll be seeing the same thing in Trinidad and Tobago.
Yes.
And guess what? It is no longer a rare occurrence to see a 600-pounder in Trinidad and Tobago. It has become our norm. Yeah. So with our decrease in activity, our increase in obesity secondary to our lifestyle changes or dietary changes. Remember, we don't eat fruits anymore. We don't eat guavas anymore. Yeah. We don't eat a lot of the fruits that are good for us. We like snacks. We like the cookies. We like the biscuits. We like the things in the pack that are processed that is driving up the rate of diabetes. So we have to be mindful of the fact that diabetes, although there is a hereditary component to it, is a lifestyle disease, and it's also a obesity-related disease. So we have to confront these issues head on. Otherwise, we will be in a crisis.
Head on.
In terms of management, and I know you had your speaker on who was a dietitian who talked about diet, there is a medication component. Yes. There's a stress management component, which is critical because stress levels makes diabetes, blood sugars out of control. My role tonight is to talk briefly about the exercise and physical activity aspect. So diet, exercise, medication, stress management. Today, we're going to focus on exercise. So when you exercise, your muscles utilize the glucose for energy. It also uses insulin more efficiently. So you don't have the issue with insulin resistance, which is key. I remembered about a year ago, I looked at one of my nurses and I said, you see your neck, it's getting dark. Yes. You have a preclinical sign. It's called acanthosis nigricans, and you have preclinical signs of diabetes. If you don't start exercising now, within the next year, you're going to convert to diabetes. You can fight diabetes once you start seeing that dark thing in your neck. Your blood sugar levels and everything may look normal, but you're already starting to become insulin resistant. And those are little signs.
Verne, I am so happy you said that.
Yes.
I'm so happy you said that because I've heard people saying, I don't know, but I'm bathing properly, I'm scrubbing my neck and this thing is not coming off. But it's not dirt. And can you explain it again to our viewers? Because as you said, that is quite often a very early sign that within the next couple of months, you will be diagnosed with diabetes.
Correct. Very correct. So diabetes is not something that happens overnight. It's a gradual process. So when it becomes clinical is when the horse is going through the gate already. All right. But before you become clinical, you have subclinical symptoms. You know, it's like having a cold. You might have a stuffy nose before, and then you get a bad attack of the cold a couple days later, right? So before the diabetes comes on, for some people, it may be the dryness of the skin, and it might be the one of the hallmark is that darkness in your neck area here. And that once you see that, if you do nothing about it in a short 6 months to a year, chances are you're going to convert and become a diabetic. That's your body. That's the signs that your body is in becoming insulin resistant. Your body's not able to utilize the insulin. It's not doing anything with insulin. It's not recognizing it. You're just,
Yes.
it's starting to, the disease is starting. It's just that you're not seeing the signs and symptoms already. So as a physiotherapist, if somebody comes to me and they have back pain or they have neck pain, and I see that, I stop and I pause and I say, I know you're here for your neck and your back, but you see that thing on your neck that you should not ignore.
Yes.
Because if you don't start exercising and you don't start doing something about it now, a year from now, you will be having diabetes and this back pain and this neck pain and this whole other bunch of issues that goes on with diabetes. So I try to educate my patients as soon as I see it, that you need to pay attention to your body from right now. This is God sending some signals for you early o'clock before you cross over. Because once you cross over, as much as people would like to say there's a cure for diabetes, once you cross over, it's much harder to go back. So you must try to do something before something happens. All right. So
thank you.
Yes. So the other thing that exercise does is that it lowers your blood sugar level. And it not only lowers it immediately after the exercises, but it can go up for 24 hours. Your blood sugar levels is lowered. So that in itself is of therapeutic benefits for a healthy body and a pending diabetic body. So you don't have the changes. I usually say high blood sugar is poison to your body. It poisons your nerves. It poisons your blood vessel. It poisons your everything. So you don't want high levels of blood sugar, and the exercises will help to lower that blood sugar. And the more strenuous the workout, the more your blood sugars will be lowered, right? Another key component, especially when we're talking about diabetes, is that the exercises will also increase your muscle strength and reduce the risk of falls from poor balance. Now, that is something that is not talked about much, but diabetes causes weakness, tightness, and stiffness. And along with the neuropathy that we will talk about a little later and all the other things that happen, your balance is also affected. And therefore, the exercise will help to prevent you from falling, breaking a hip, and hurting yourself more, and which could in turn prevent you from engaging in meaningful therapeutic exercise to help you to live a better quality of life. So prevention of falls and improved balance is critical. So before starting an exercise program for people who are not used to exercising, if you've always been exercising, this is good. If you're starting from scratch, if you've never exercised before, it is very important that you undergo a detailed medical evaluation. All right. And a detailed medical evaluation would mean that you want to make sure your heart is okay. You want to make sure your kidneys are okay. You want to make sure that your blood vessels are okay in your neck. So there are lots of things that you want to make sure, because you don't want to go and start exercising and you end up with a heart attack because you have blockage in your in the vessels in your chest. So you must be evaluated for macro and microvascular complications. And the macrovascular complications would be like the strokes, the heart attack,
Yes.
those pending bigger circulatory things
Yes.
that can happen to you. But the microvascular circulation issues will be the retinopathy that was talked about
Yes.
at the last presentation. So you want to make sure that your vision is good, because poor vision
Yes.
can lead to falls. Poor
Yes.
vision can you can hurt yourself if you have poor vision. You might walk into something, stump your toe, and then
Yes.
you develop an ulcer, and then the whole thing just starts to go downhill from there.
And I
So
had a
you want
client
to
Verne,
manage
with
vision. Yes.
I had a client with severe diabetic retinopathy a number of years ago, who was given the advice, well, walk or lift some weights. No clarity, not from a physiotherapist. And of course, this person went with all their exuberance and started doing deadlifts, and the retina detached. Because
Yes.
if they were properly screened before and the severity of that diabetic retinopathy discovered, proper advice could have been given that they would have had to maybe use lighter weights, nothing with any set of strain, what we would call Valsalva movements in medicine,
Maneuver. Correct.
to,
Yes.
to prevent that. And so it is vital. It's easy for someone to be told, girl, go and start to walk, go and lift weights. But as Verne is highlighting, it is imperative that you undergo a detailed medical eval, especially if you have not exercised before and or you have not exercised in a long while.
Yes. And so that's the retinopathy part. Then there is the kidneys. You have to make sure that your kidneys are functioning well, because again, those microvascular damages that happen from diabetes can also compromise your kidney. And back home to the legs, you want to know if you have sensory loss, if you have loss of feelings in your feet from damage, from nerve damage, from diabetes. So that's called neuropathy. You want to also know if you have decreased circulation, decreased arterial flow down to your feet from diabetes. Because if you start walking, you put on any shoe, and the shoe is too tight, poorly fitting, and you start walking, you will get a bruise. And again, that bruise can be the start of an infection, of an infected wound, if not managed properly, which can ultimately lead to an amputation. I have seen people who tell me, the doctor tell me to start to walk. And I start to walk around the stadium. And when I started, I got a bruise on my foot, and this is what it turned into, right? So if you have foot issues, if you have loss of protective sensation, if you have problems with arterial flow, you have to be careful. You have to be wearing adequate footwear so that you don't get injury from your shoes, because if your shoe is tight, you would not be able to feel it. If it's too loose and your foot is moving too much in the shoe, you can get blisters, and that too can cause its own sets of problems. So we really have to be mindful of what is going on with our limbs, with our legs, before we start an exercise program.
Yes.
And you want to identify other areas of concern. So we say you need to exercise, but how many diabetic patients just have diabetes? Very few.
Very few.
So
very few.
You are diabetic. You may have back pain. You're diabetic. You have osteoarthritis in the knee, the ankle. You may have deformed toes. You may have calluses. You may have an old ulcer and you start walking, and then we end up with more problems than you bargained for. So we have to really be properly evaluated in order to make sure that our exercise program is a success. And when you have the complications, the old ulcer below your foot that was there that healed 5 years ago, that would have left a callus, or you have a corn or a callus on your toe, or you have a hammer toe or clawed toe, or your toes are crossed over, we have to bear that in mind when we are developing an exercise program for you, because we first of all have to decide if walking is the best option for you, because sometimes it is not, and it is not practical to get everybody walking. So we have to decide, do we chair exercise? Do we lie down in bed and do the exercise? We have to get the exercises done, but we have to find a way for you to exercise safely. Yes. So before you begin to exercise, this is on the day of exercise. You want to make sure that your blood sugar is not too high or not too low. At either extremes, we can end up with serious complications. So if it's too low, you start exercising and your blood sugar, you run the risk of your blood sugar becoming lower. So you can end up with a hypoglycemic episode. If it's too high, we run the risk of the blood sugar either dropping too quickly or increasing also. So on either extreme, so if it's over 250, although I do have some patients at 250, they're okay, but I'm not advocating it. But over 250 and over, we have to have a discussion with our doctors or healthcare providers. Saying, okay, I wanted to exercise this morning, but my blood sugar was 250. What do you think? The doctor knows you, the doctor knows your medical history, and therefore would be best able to guide you. We talked about the shoe, wearing adequate fitting clothes and shoes. It is so important that I see people walking with thong slippers. A lot of patients in Tobago tell me that they don't like shoes. So they will go walking in slippers, right?
Or barefooted.
Or barefooted in some case, or they go walking in a bedroom slippers, or in a pair of shoe that is so inappropriate, an old-time Converse or something like that, that would potentially cause problems. So we have to be careful that our clothes is well fitted. We don't want to wear really tight leggings, because if your circulation is compromised and your leggings are too tight, you could further compromise your circulation. We don't want to even lace the shoe up too tightly, because it will cause circulatory compromise. We don't want to do things like that. Exercising in a fasted state. Again, this is something you have to discuss with your healthcare provider. It is generally not recommended to exercise in a fasted state, but again, every individual is different. So you have to talk to your medical care provider, your physician, your diabetic educator, your dietitian, to find out which is the best approach for you. Because there are people who would wake up first thing in the morning and they want to exercise at 7 o'clock in the morning. And then there are people who want to exercise at 4 or 5 o'clock in the evening. So you have to work with your healthcare provider to find out when is the should I eat before I go for a walk? Should I drink something? What should I do before
Yeah.
I go for this walk? And
Because someone
sometimes you
just
have
sent
to
in an
experiment.
email, Vern, and
Yes.
just what you're saying, somebody just asking the question, when is the best time to exercise? And you're answering that. So for the person who emailed in that question, when is the best time to exercise? As Dr. Verne is saying, you may have to experiment to see when is the best time for you. But for sure, as a rule of thumb, you don't want to exercise in a fasted state where your blood sugar may be below
Good.
85 to 90 milligrams per deciliter. All right,
Yes.
so you keep this in mind. Very, and it's ironic that you're talking about it, and this person just that email just came in. So keep your questions coming
Yes.
in, and we'll answer as we go along, folks.
Yes. The other thing is hydration. Dehydration could wreak a havoc on you even if you're not exercising. So it could put you into a hypoglycemic state. So you want to make sure that once you're on an exercise program, once you plan to exercise, you have to hydrate, and hydrate.
Yeah.
I used to run half marathons. And one of the things we learned is that the day before the marathon, or up to 2 days before the marathon, we have to drink more. We have to make sure that we are really, really, really hydrated. And so as a result of that half marathon training, as a rule of thumb, once I know that I'm waking up to exercising in the morning, once I'm going to the gym, once I'm going for a long run, I am going to start from the day before with the hydration part of it, because strange things happen to even healthy bodies when they are dehydrated. So if your body is already compromised by diabetes, you want to make sure that you're hydrated. And since I'm on the topic of half marathons, shoes, exercise shoes, as a rule of thumb, although I don't like numbers where shoes are concerned, you see this? I wear a size 8, I wear a size 10. That means nothing to me. A size 10 in Vietnam is not a size 10 in England. It's not a size 10 in Trinidad and Tobago. So the quicker we move away from the numbers of size that you have, the better it will be for you. So the ideal thing will be to try on your exercise shoe. So although I said I don't like the numbers, but for ease of learning, if you are a size 10 and you're going to exercise, your exercise shoe needs to be a size 11. So your exercise shoe needs to be one size bigger than your everyday shoe. Why? Your foot expands during exercise. And you want to give your foot and you want to build in that room for expansion of your foot during exercise without causing any damage to your foot. So size 10, exercise shoe, size 11. Okay?
Yes.
And we talk about clearance from your medical
Listen to
professional.
these tips, folks. You're not going to get these. When you go to purchase your exercise shoe in stores, you're not going to get this information. So be guided accordingly. If you are living with diabetes and you're intent, you must exercise. You're going to do some walking, some light jogging. You're going on a treadmill, on a bicycle, because your foot can expand. This is a free tip. You would have to pay for this otherwise. Buy a shoe one size up to compensate for that expansion. I love that. I'm going to use that from tomorrow with my patients, Vern. Thank you.
Yes, one size up. Yes. So we talked about while you're exercising. So you started your exercise, you're walking. You want to stay hydrated while you exercise, especially if you're exercising for extended period of time. If you're doing it for 30 minutes, chances are you may not need to drink some water in between. But if you need to, go ahead and have the water, because again, hydration is key. Because when you're exercising, you're at risk for having a hypoglycemic episode. You have to be prepared. Be prepared. So you have a small snack. I would say keep a sweetie in your pocket or something, so that if you happen to go hypo, you have something right there, right now, to help to bring your blood sugar back. And with that in mind, it's better if when you're exercising, you exercise with company for safety, just in case you have a hypoglycemic episode.
Yes.
No, I'm saying that with a bit of caution, because I will have patients who would tell me, when I ask them about their exercise, say, "Oh, I didn't exercise. I didn't have nobody to go with, so I can't exercise." That's a very good excuse. And a very frequent excuse. So your grandchild not around, your daughter not around, your friend didn't come, and you can't exercise. So we have to put in some safety mechanisms in place for when your granddaughter and your children didn't come, so that you can still exercise. So with that in mind, for the safety concerns, you may want to tell somebody where you're going. I'm going to exercise and I'm going for 30 minutes. You could text them, WhatsApp them, do something. And when you come back, you do the same thing. So the excuse of I can't go because nobody ain't with me, we have that covered. Use the phone, take your phone with you, and text when you're going, what the route is when you come back, for safety. One of the things that
asked Verne,
yes.
How do you know if you're having a hypoglycemic episode? What are the symptoms of a hypoglycemic episode? Thank you, Melly, for your question.
Most people tell you they feel bad. I just feel bad. I don't feel good. They may start cold sweating, or they can pass out. Yes. Yeah, those are the typical, the cold sweating. They may start shivering also. Most diabetics know what their symptoms are. And this is one of the points that we're going to get to, is know how your blood sugar respond to exercise, which is why we can't go out and run a marathon on the first day. So you want to, if you've never exercised before, you may want to go for a walk. You take your blood sugar before the walk. You go for the walk, you come back, you take the blood sugar, see how it's doing. In about an hour or so, you take the blood sugar again, because your blood sugar can be going down for several hours sometimes, minutes to hours, even after the exercise. So you want to understand your body. You want to understand how your blood sugar responds to exercise. So in your early days of experimenting with exercise, you want to pay attention to how you feel, and you want reliable information from your glucometer as to how your blood sugar doing. So if you walk for 45 minutes and when you come back, your blood sugar is down to 60, then you know that you need to get some sugar in after that 45 minutes. So if it's 30 and you find that it's going down to 70, so you need to get some real-time feedback as to how your body responds to exercise.
Yes.
The same goes with if you're on insulin. If you're taking insulin, you have to take some time out to figure out how your body responds to the current insulin regime that you're on, how it responds to the time that you take your insulin and the time you exercise. And again, this is something that you will have to work out individually with your doctor, with your medical care provider. So you have to really pay attention to your body to decide how best to manage your symptoms, how best and how to recognize them when they come on.
Yes. Come on.
So you are exercising, and let's say you decide to go for a 30 to 40-minute walk. And while you're out there, you start cold sweating, you start shaking, and you're having a hypoglycemic episode. There is something called a 15-15 rule. If you're having a hypoglycemic episode during exercise, you need to stop and get treatment immediately. And the treatment is some form of sugar, right? So it could be you check your blood sugar, and then once you realize that your readings are low, less than 90 to 100, you can get some soda, a little bit of sugar, a teaspoon of honey. You can get a sweetie, the sweetie that's in your pocket that most of you carry around in your bag. You put that in your mouth. You wait for 15 minutes. You see how it is. You check. If it's still low, you do another round, get some more sugar in, see how it is, and repeat until you get your blood sugar back to over 100. And of course, if you have this episode, you need to talk to your doctor. So you go back and you say, Doc, I was walking for 30 minutes. And within that 30 minutes, I had a hypo episode. And I need to know how to move forward from here. It could mean that the doctor may have a discussion with you about adjusting your medication. It could be adjusting your meals. It could be so many little adjustments you need to make, but you don't make a decision on what to do by yourself.
By yourself. Yes.
Yes, you need to take this feedback back to your physician and tell them what has happened. And sometimes it takes a while to get to the bottom of what is going on, but it doesn't mean that you have to stop exercising. You just have to find out how best to do it without getting the hypo episodes.
And we know our trainees are excellent at following the advice of Dr. Google and Dr. Neighbor and Mary Jane down the road, because they stop their medication. So I'm going to stop mine. I don't have to go back to the doctor. No, we say this every show. These guests have not even collaborated before, and all the messaging is the same. If you have to make a change, you need to have a conversation with your primary doctor, usually your GP. Don't be afraid to have a conversation. Let them know what is happening to you so that you all can work together to make the necessary adjustments. Too many times people stop taking their medication because, oh, the sugar was good today or the blood pressure was good today. You're putting yourself at risk of having a major episode such as a stroke or heart attack. So don't self-medicate, don't self-diagnose. See your doctor. Thank you for reminding us of that, Verne.
Yes, and I want to also add this in. For the people who want to go over and listen to the ads that say diabetes can be cured, I think I feel confident enough to tell Trinidad and Tobago, if anybody want to sell you something and tell you to stop your medication, please take a while, sit back, do your research, talk to your doctor before you make that decision. There are too many victims of diabetes and high blood pressure who were sold supplements and all other fancy diets and were told to come off their medication with the guarantee that they will be cured. Please, ladies and gentlemen, do not stop taking your diabetes and high blood pressure medication as a trade-in for bush medicine or for herbs or whatever. This managing diabetes is a team approach, and no one person has all the answers. You need to you need to manage your diabetes in conjunction with medical professionals that you feel comfortable with. Okay, so please try to avoid getting caught up in the ad world where people want to sell you all sorts of things in exchange for curing your diabetes. It is very highly likely it's going to happen. So just to piggyback a little bit on exercise. So we talked about exercise and exercise for therapeutic benefits, but I have a lot of retirees that spend the day watching TV, or they spend the day not really doing anything. And so therefore, all they might get is a pocket of 1 30-minute episode of walking, and they think that that is good enough. Or some people might go as far as telling me, I walked around the house. And my question usually is, do you live in Buckingham Palace? Because unless your house is really, really large, you have not exercised. Don't be confused with living and exercising. They are two totally different things. So, in terms of activities, especially if you have a desk job or your job does not involve a lot of movement, you need to get additional activity in. So it could be anything from gardening to raking and sweeping around the house. Remember when we used to sweep the yard almost every day? Stacy, you might be too young to remember that, but there was a time.
No. My mom did a lot of that. I would just watch though.
You had to sweep the yard every day. There were some therapeutic benefits for that. Playing with your grandchildren and children, taking dance lessons, any opportunity you can get to get some movement. Sometimes I tell my patients when they're really, especially the retirees, what do you do? I make breakfast, I cook, and then I go to bed. I would say, you know what? Go and find a job in a supermarket. That way you will be moving a lot. Don't look for a security guard job. You're going to look for a job that makes you move. You're not doing it for the money. You're doing it for your health. All right? So if you sit down and you reflect and you look at the amount of time you're sitting, that 1 30-minute episode of walking for exercise a day will not be enough. So you have to find a way to increase your activity level. So we do the dance lessons, we play the tennis or the team sport for the younger people. And I say swimming, and I put a lot of asterisks next to swimming because I am from Tobago. And yes, swimming is good, but not if you have a diabetic ulcer. The sea can infect your wound. So if you have any open ulcer, please do not swim. Walk after dinner. Again, You want to increase your exercise activity, but you want to be safe in the process. Walk with your dog. If you have a pet, sometimes people ask me, what kind of exercise machine to buy? I would say, the best exercise machine is a dog, provided that you can control it
That's
and
so true.
the skin doesn't run across your foot and all that. But you have to take the dog for a walk. It is very unlikely that you're going to hang clothes on that dog. So
Yes.
the treadmills, the bicycle, you use them for the first month and then they're done. So my test is, if you can go for 4 to 6 months of going for a walk consistently, then you can buy the treadmill or the bicycle. If you can't maintain that, you will just be buying a piece of furniture.
Correct.
Another
or a
thing,
towel holder.
a towel holder. Yes. Wash your house, clean around the house. Just do things to keep you moving. Moving is therapy. So that's the exercise component of diabetic management. So it's deliberate exercise. You're going for the 30, 45 minutes, an hour walk. And it's also activity, especially if you have a sedentary lifestyle. So you're looking for every opportunity to move. Okay, so our next segment is diabetic foot disorders. And this is the part that is very personal to me, again, because like I mentioned earlier, my father died from complications of diabetes. And believe it or not, the major source of morbidity and the leading cause for hospitalizations for people with diabetes is diabetic foot issues. And if you have a diabetic ulcer, diabetic foot problem, just a small ulcer, infection, gangrene, amputation, these are significant complications of diabetes. And they are life-changing complications. Once you lose a toe, you get an infection, you develop gangrene, life is never the same again, and your life expectancy also decreases. So, of all the people who have diabetes, about 15 to 20% of those people with diabetes will develop an ulcer. And believe it or not, about 85% of the people who have a lower extremity amputation, it is as a result of diabetes. Wow. The other percentages are people with
Verne, when I worked in San Fernando General, the foot amputations, the main cause was poor circulation. Now, I mean, that is just an amazing figure. A direct, not an indirect, a direct result of living with diabetes if it is uncontrolled, if we don't take the steps. Wow.
I wanted to show a screen here, which is it's a very disturbing screen for most people who are not aware. And this is a factual piece of information. This is the life expectancy, the relative 5-year mortality rates for people with different diseases. Yes? So we hear people talking about breast cancer, prostate cancer, and all these kinds of different cancers. But what we don't know is, if you look at this, I hope you're seeing this chart here.
Yes.
Right. If you look at, are you seeing my my cursor there?
You're seeing the cursor.
Yes, you see that?
Yes.
This is pancreatic cancer. Is a cancer that is most likely to kill you within 5 years, followed by lung cancer, followed by peripheral artery disease, which is a complication of diabetes.
Yes.
Not prostate cancer. Notice that is not prostate cancer. Prostate cancer is all the way down here.
Down.
Peripheral artery disease, which is one of the microvascular complications of
Of,
diabetes, is more
yes.
likely to kill you than colon cancer. An
Wow.
ischemic diabetic foot ulcer, that's a diabetic foot ulcer with circulation problems, meaning with arterial circulation problem, is more likely to kill you within 5 years than colon cancer. If you had an amputation as a result of diabetes, you're more likely to die from that than breast cancer and prostate cancer. So I hope Trinidad and Tobago people who are listening realize that diabetic foot issues are real, and they will kill you just as fast as would lung cancer, breast cancer, non-Hodgkin's lymphomas, and all these things. When somebody say, I have breast cancer, you go, oh no, I'm so sorry. But if somebody say, I have a diabetic foot ulcer, you don't get the same response. When in truth and in fact, it is more likely to kill you than the breast cancer. And you hear people all the time telling you, go and get your breast screen, go and get your pap smear done, go and get your prostate check. But you never hear, go and get your foot screen, because if you catch complications early, you can increase the quality, have a better quality of life, and you can increase your lifespan just by getting early screening, early intervention for diabetic and prevention of diabetic foot complications.
Wow.
Hello? Yes. So I just
Definitely
wanted to
reality check.
bring that. Yes, I just wanted to bring that up. So diabetic, I think I lost a slide here. Let me see. Right. So every 20 seconds around the world, a limb is amputated. I don't know how frequent it is in Trinidad and Tobago, but definitely it is an issue, diabetic foot ulcers. And again, you lose a toe, you lose parts of your foot. It has serious impact on your quality of life.
Yes.
So, dangers of diabetic foot ulcer. If you have a diabetic foot ulcer, you're more likely to have a premature death, heart attack, fatal stroke. So these are things that we need to be mindful of. And we talked about the complications. Now, the good news about diabetic foot complications is if we start early screening and we prevent the complications, if they get early, adequate, optimal intervention, we are less likely to have complications. So managing an initial insult correctly the first time around is really critical in deciding the outcome of a diabetic foot episode.
How often, Verne, should a diabetic have their feet assessed without any complications? Once a year. And so once anything is identified, then
then yes. So depending on what is identified. So once you do that once a year check, if you have neuropathy, then you want to check back every 6 months. If you have neuropathy with ischemia or decreased circulation, then you want to check back more frequently.
Yes.
I think,
and that is having your feet checked by a professional,
by a physician. But yes, by a physician or a healthcare
professional. But remember, everybody living with diabetes, you should make your once daily check on your own at home. If you can't reach your feet, have someone look at your feet for you. And there are also these lovely mirrors with these long handles that you can stretch out so you can look and see under your feet. Because quite often, persons who have neuropathies and they get a wound, they don't even feel it. They realize something is wrong when they start to smell it. And that is a reality. We're telling you the reality of the patients that we have treated and continue to see. They are unaware there's a wound until they smell it or until they may see stains on their socks. They wear light color sock. So do your self check daily, but every year. If you have your neuropathy every 6 months, if you have added issues, it will definitely be more frequent than that.
Every 4 months.
Thank you, Vin, for the
You're
reminder.
welcome. Right. So, so there are different types of diabetic ulcers. So if you happen to get a diabetic ulcer, there are different kinds. And depending on which type of ulcer you get, it will determine how fast it would heal, if it would heal at all, the complexity of treatment, and the general outcome. So if you have an ulcer, what we call a neuroischemic ulcer, that's an ulcer where you have damage to the nerve, which is called neuropathy, the loss of sensation, and then you have decreased blood flow coming down from the arteries. That will be a more complicated ulcer than if you just have a neuropathic ulcer, which is just a diabetic ulcer without the circulation component, the severe circulation component that goes with it. The neuropathic ulcer patients tend to be a little, they heal faster because they have better blood flow, right? The patients with the ischemic ulcers, diabetic ulcers, those patients are the ones that are least likely to heal and would require vascular surgeon intervention. So it doesn't matter what you do. If you don't get the blood flow, the blood to start flowing through the arteries again, the person will lose their foot. And I will also go out on a limb and say that I have seen quite a few ischemic ulcer patients who are not diabetic. So while it is more common in persons with diabetes, people without diabetes can also have ischemic ulcers. So another good reason why you need to exercise, whether or not you have diabetes, because if you're a frequent exercising person, you are less likely to develop ischemia or ischemic ulcers of the legs. And so the exercise will help the blood to flow down to your toes, the tips of your toes and your lower leg in a more efficient way than if you don't. So you can have an ischemic ulcer without being diabetic. However, if you're diabetic, it's going to be a way more complicated course of a way more complicated type of ulcer to have, and ischemic ulcers kill people. So if somebody have a severely ischemic ulcer and they don't get proper vascular surgeon intervention, they can actually die within a few weeks from it. So there are certain things that there are certain factors that would contribute, as we talked about, to developing a diabetic foot ulcer. Neuropathy, that is because of the decreased circulation and because of the poison that the high blood sugar, the high blood sugar, this is my easy way of saying this, the high blood sugar poison the nerves in your foot. And that is an irreversible poison. Once the nerves are damaged, we can only treat the symptoms we can't cure it. So that poisoning of the nerve, and I'm using that word very loosely, you would not see it in the literature, causes neuropathy, and it results in decreased sensation, meaning you will be the person that will walk with on your grandchildren's Lego all day long and not feel a thing. You will step on a nail will be stuck in your slippers or your shoe, and you will walk on it for an entire week and you will not feel a thing.
That's right.
You will walk. I have had patients who went to the beach, came back and stand on the pitch, on the tar, on the asphalt, and stand there and burn their feet off and did not feel a thing. That's how severe neuropathy can be. That's the same patient who would argue with me and tell me, but I shoe real comfortable. And I would look at them and say, you don't know that it's comfortable. The shoe is too tight for you. You can't feel it. And they will argue with you down to the bone and tell you, the shoe real comfortable. I like that shoe is real comfortable. And it's destroying their foot and they're not feeling a thing.
Feeling it.
Exactly. So again, you will walk on fire and not feel because of neuropathy.
Yes.
The other complication that comes along with diabetic foot ulcer is deformities. That's when your toes are clawed, they're crossed over, they're missing, your foot is, you have the hammer toe, you have all sorts of deformity. Your ankle is twisted. You're walking on your toes more. Those deformities are as a result of the changes that occurs with diabetes. Diabetes has a way of wanting to tighten up your body. And sometimes that results in the deformities of the toes and the fingers too. And so as a result, you are more likely to develop an ulcer. And the reason why you would develop an ulcer is because you change the way you walk. All right. The other thing that neuropathy can also cause is what we call fat pad atrophy. Below the sole of your foot is supposed to be a little fatty. All right. But when some of the fat disappears, you end up walking on your bones. And the bone causes friction and that causes ulcer to develop. Limited joint mobility, stiffness in the ankle, stiffness in the toes, stiffness in the joints. Stiffness can cause ulceration because you will put excess pressure on certain areas of your foot that you more than likely would not if you were walking in a normal sense. Poor glucose control, will say it and will say it and will say it again. And every time you hear diabetes presentation, you will hear the same thing. If your blood sugar is not controlled, bad things happen.
We can't say it enough.
Things happen. All right. So I speak to the men especially, and they don't like to hear this, and I will say you will get erectile dysfunction if you don't control your diabetes. Okay? Losing the toes and the feet doesn't scare them as much as erectile dysfunction does. And it's a fact. If your blood sugar is poorly controlled, besides all the diabetic foot complication, you risk having Alzheimer's, you risk having a very miserable, torturous life. The kidney failures, the strokes, the heart attack, the everything. So it all comes back to you. You have to take ownership of your diabetes, what you eat, and controlling your blood sugar. You already have it. The best you can do is work with what you got. You have to control the blood sugars, because if you don't, You can meet the best wound care specialist in the world. It is
That's right.
not going to heal.
I heal.
Blood sugars have to be controlled.
That's right.
Duration of diabetes. After my dad died, I think I was doing my master's, and I had to do a paper on diabetes. I had to do a literature review on diabetes. And my take-home message from doing the literature was, I come from a big bone family. That's what everybody says. Everybody in Tobago come from a big bone family. We're Black, right? So we're of African descent. We big boners. That's the number one excuse. And everybody in my family have it. Right. That is me. I fit the profile. But what I can tell you is I grew up with an aunt who was diabetic. My dad was diabetic. His sister was diabetic. So I come from a strong history of diabetes. What I learned from my paper is, if we don't do the things, if we don't do the exercise, if we don't manage our diets, we can start being diabetic at 20 and 30. But sometimes, even with doing the best, we still end up with being having diabetes because we're kind of genetically coded for it. But if you develop it at 80 and 90, then you don't have to deal with all 20 to 30 years of diabetes. So even if you're big bone and everybody in your family have it, you could buy yourself some diabetic free time by doing what you need to do to control your blood sugar. No, even before the diabetes come on. So you don't have to be living from 20, 30, 40. You don't have to go through your 30s and your 40s with diabetes. If you get it when you're 70 and 80 and 90, you're closer to your maker. And you would have enjoyed a better quality of life, diabetic-free life, than if you have it when you're 20. Because the longer you have the diabetes, the more likely you are to develop complications of it, even if you are really good at controlling it.
Yes.
So if you could, although the family is big bone, push it off for a couple of years, work at that before you get it. And males are more likely to have diabetic complications than females. That's what the literature says. And trauma from poorly fitting footwear. You see how this footwear thing come back and back and back again. And the research says 80% of people who develop foot ulcers or foot trauma develop it from footwear. So your shoes, or sometimes I like to call them your foot coffins. A foot coffin, that is not a shoe. That's a foot coffin. So what I do with my patients, after the wound is healed, they're supposed to bring in their shoes, the whole suitcase of shoes, and we will go through and disqualify the foot coffins. You can give this one away, give this one away, give this one away, give this one away, because we don't want the ulcers coming back. Because once you had an ulcer, the likelihood of getting another one back is about 50 to 70%. So prevention is key. So we have to screen, look for the foot coffin. Sometimes we even have to be shoe detective, A patient is coming in and something not right. This also. We can't get them to wear what we want them to wear. So they're wearing what they have, and we try to compromise and manipulate the shoes the best way we can. And yeah, of course, they will wear other shoes in the meantime. Some of them will tell you yes, some will tell you no. But we have to be foot detective, and sometimes we have to look for which shoe is causing the problem. And so we have to be shoe detective, and patience. You have to be a shoe detective too, because sometimes the shoe that you're wearing might be the thing that's preventing your foot from healing.
Yes.
So, as we mentioned before, this is going to get repetitive, and I'm repeating because I want stuff to be reinforced, right? How to decrease the risk of amputations. Once you have diabetes, you need to be screened at least once a year. Ladies, once you have a breast, you need to check it at least once a year or once every 2 years. Yes,
that's right.
They tell us that all the time. Men, they have their screening for their prostate. Yes, we've been told that, but we're not being told once you have diabetes, you need to screen your foot once every single year. If you have problems, you need to go and keep looking at it, keep checking it. Your health professional need to make sure your calluses are trimmed, your nails are trimmed, everything is fine, so that you don't develop complications. So we do the foot screen. We manage simple foot problems before they become an issue. So the nails, if we have long nails, if we have nails with fungus, if we have crooked nails, if we have raised nails, any nail issue, we need to address the nail issue. If we have callus, the callus needs to be trimmed frequently. And what we do with our callus patient is look at the rate that the callus is growing. So nurse will say, this is 3 weeks, this is 4 weeks, this is a 6 callus. So depending on the rate that the callus is growing, depends on how frequently we see the patient to reduce the callus, because the callus will turn into an ulcer. So sometimes patient will tell you, every time the wound heal up, it open back. I don't know now, and in Tobago it's always obia. It is not obia. It is the callus that turns into a stone. It's like a stone. If you were to have a callus on the sole of your foot, it will hurt you too much if you're not diabetic. Because you're because you're diabetic, you're not able to feel it. For the same reason why someone with severe neuropathy can stand on the hot road and not feel it, for the same reason you will have a callus on the sole of your feet, on the side of your feet, and not feel it when you're wearing a shoe that's not appropriate. Again, appropriate shoe selection. We can't overemphasize that you're not a size 10. You're the size that fits you the best in length and width. Stop telling your grandchildren to buy you a size 10 shoe, because if it's made in
I try to fit into smaller sizes. You're hurting me here. Shoes and pants.
No, it's not.
I'll try to fit into my size from now on.
Yes, please do. You don't want to, the other thing you don't want to do, you don't buy a pair of shoes and say, it got stretch, man. After I wear it for a while, it got stretch out. You don't stretch out a shoe on your diabetic foot. If the shoe is not fitting you well in the store, it doesn't matter how cute it is, leave it alone. It is not yours. Okay? Stacy mentioned earlier on about daily self-inspection. This is critical. It is critical because, again, because you lose that feeling. You don't know when the shoe is too tight. You don't know when you step on that nail. You don't know when you step on that thumbtack. You don't know when the shoe rubbed on your foot because you're just not able to feel it. You have to look at it with your own eyes, or you take a mirror and look at it. If you can't see, you have to ask someone to do your foot inspection every day or as often as possible. And I like to say, if you see any brown thing below your foot that you've never seen before, even if it's not bleeding or it look to you like it's not bleeding, if it's brown or black, it's probably what we call a pre-ulcerative callus.
Right.
That means that little brown spot or that little black spot, once you leave it, it would convert to an ulcer because it's usually a site of trauma. So if you see, so you're not just looking for blood or blisters, you're looking for brown spots and black spots. And those need to be attended to immediately because they are pending big ulcers coming. Patient education is key. So patient education is, please inspect your foot every day. Look at it. Have somebody look at it for you. Get the mirror. Shoes. Wear the appropriate shoes. This shoe that you're seeing on the screen here is a shoe that my patient, that I try to get the appropriate, to wear the appropriate footwear. And what he will do, he would keep the shoe in, he will come into the facility with this shoe on. He will come to the front door with the shoe on, take this one off and put on the appropriate one to come
trying to fool us.
Come into my office. And we could not figure out, well, we kind of figured out that he was non-compliant, but he looked for a while like he was doing okay, but we couldn't figure out, okay. Then we saw him with the shoe. We couldn't get him away from the shoe. And this is one of the worst shoes a diabetic could wear. So if there's anybody who is diabetic and have any foot complications, this is not your shoe. Patient education, callus. If we look at this foot, this is a highly neuropathic foot, and this foot doesn't look as if there is an ulcer, but there's actually an ulcer on this foot. This is actually an ulcer. It's a callus that's converted to an ulcer. So we'll have to remove all this and treat the ulcer and offload this foot. So this is why. And this patient would have had this ulcer years ago, and because he was not getting the callus reduced on a frequent basis, it just stayed and built up like this. So this is why we need to see people on a regular basis. And this red spot, this brown spot here, so also that's probably indicative of some kind of trauma that he may have also. All right.
Wow.
So patient education. For all the sexy ladies out there who love to wear acrylic toenails, it is not your friend if you're a diabetic. So my attention is right here. There are a couple of things that's really wrong with this for a diabetic person. When you put on the acrylic nails, it looks really nice, doesn't it? When you put on the acrylic nails, the risk of getting a fungal infection increases. Yes? And a fungal infection could lead to a toe infection, which can cause you to look like this. All right?
Yes.
In addition, if you notice, this nail is about 1/4 inch longer. So if you wear a shoe that is probably your correct size, you can injure your toenail because
Yes.
the tip of the shoe, especially when you're going downhills, downstep, will be pounding against the front of your shoe, and that can cause nail trauma.
Yes.
In addition to that, something can get caught on this toe, this extended nail, a
Yes.
sheet, a piece of string, and anything
Mm-hmm.
can get caught here and it can pull your nail. Okay? And that
Yes.
can set you up for a whole big diabetic foot drama. So I
Wow.
always tell people, feel free to paint your nails. Ladies, feel free to paint your nails, but this is a danger to your foot.
Yes.
Very important. And even if you don't put acrylics on, having long nails is also
Mm-hmm.
risky because of the potential for trauma.
Yes.
This diagram here on this side is I do it for patients to understand the difference between a shoe fitting your foot and a foot fitting into a shoe. If you look at the red outline,
Hmm.
this is uh this is a person's foot. Yeah? But the blue outline
Yes.
is the outline of the shoe. Your foot is supposed to fit in the shoe. So you can
Hmm.
look at this diagram and see that the foot is too wide for the shoe.
Wide.
Yes. And so you have the potential to cause ulcers on this side and ulcers on this side of
Mm-hmm.
your foot. So not just the length of the shoe
Yes.
has to be appropriate, the width also have to be appropriate.
Yes.
And this is what happens if we continue to wear shoes that are not appropriate. And then if we don't
Mm-hmm.
have proper offloading. Any questions so far?
I think at this point it's just amazing what something seemingly small can morph into if we're not careful. And this is the reality. And it's not good enough for us to say, well, that can happen to me. It can't happen to you if you follow these guidelines, if you practice the self-care, if you practice get sugar under control. But if you do not follow the diet, the exercise, the medication, the stress management, the daily assessment of your feet, etc., having your yearly checkup, and more if necessary. That picture that I'm sure many of you all are like, oh, that can be your foot. So this is a reminder, viewers. This is a reminder to everybody. And something somebody just messaged. I usually see about my own calluses at home with a razor blade. Lord have mercy. What do we say about those who still utilize the shavers and the razor blades to gently get rid of their calluses wound?
I discourage it. I discourage it. I discourage it.
Yes.
I discourage it. I discourage it.
And quite often the calluses get thicker, they grow thicker.
And
And I've had one or
mhm.
two patients who cut themselves and ended up
Yes,
having to go to the accident and emergency.
correct. Yes. Yes, I've had more than one or two. I had
Oh my
quite
God.
a few to tell you it's not a good practice.
No, it isn't.
So that brings me to the end of
So
this
we,
segment. Hello?
oh, this is fantastic. Yes, Vern, we're hearing you.
Yes, so I'm open to questions.
Are you
If
hearing
we
me?
have any,
Yes, good.
yes, if we have any questions,
Do we have any questions?
um if not,
I have some people commenting that this is a shocker for them. And I think, Natasha, you're not the only person. A lot of this surprise of us are quite unaware of the long-term negative effects of living with diabetes if we are not living well. We are unsure of what some of the effects can be. And I think Dr. Alleyne has done an exceptional job at bringing home to us a little closer in a practical way, in a down to earth way, what can happen. Sabrina Roberts has asked if you can show us the picture again, the picture of the foot with the ulcer that is unhealed. Sabrina,
yes,
this is for
actually
you. I'm sure who else wants to see it.
this person, I sanitized my presentation today because I had so many pictures and I thought I would just gross people out. So I sanitized it to save people. But this person will actually walk into the department and would just look at you like nothing is happening. This is not even
Yes.
painful. So pain is a gift. And when
Wow.
you have diabetes, that gift of pain is taken away from you. And that's why you can do that.
Wow. Somebody has asked an interesting question, Vern. I'm going to put it up on the screen for all our viewers. And Marsha Forrester, who's asking the question. Hi, Marsha. Marsha has been one of the viewers looking at almost all our shows since the first episode. And Marsha is asking, diabetes, fungal infections like athlete's foot, is there a relationship between the two?
Yes, there is actually. Well, there are two things here. There is the diabetes fungal infection, and there is another thing that's called a soft callus that sometimes get misdiagnosed as a fungal infection.
Yes.
And it's like a callus that's between the fourth and fifth toe, but it's usually extremely painful
Right.
for those people who can feel. And if we don't get it properly diagnosed, then we can be treating a soft callus for fungal infection. So that's one. Two,
Yes.
because you have circulatory compromise, because you have neuropathy, because you have dryness of the skin, decreased blood flow, fungal infections, it will be more likely in patients with diabetes. So yes, it's a reality. You have fungal nail infections or fungal infections like athlete's foot between the toe, which is fairly common.
Yes. Thank you, Marsha, for that question. And I know some of you may still have questions. Vern has given us so much of her time and her knowledge. Vern, thank you so much. This has been invaluable, not only to the viewers, it has been invaluable to me, reminding me of some things that I need to look at when I assess a patient, some of the things that we sometimes take for granted. And for those of you who still have questions, you are reminded that during the month of November, I will be posting some of your other questions that we didn't get a chance to touch on. The same experts will answer, and I will post them up on my page. So don't worry, you're not going to miss out. Just keep in tune with my Back in Motion Physical Therapy TT Facebook, Instagram pages, the YouTube channel as well, and email us at backinmotiontt@yahoo.com. And I have a special prize that I decided that I would give for all those who asked questions tonight on the live stream during the live show. I am going to sponsor you. I shouldn't say I, Back in Motion Physical Therapy Services will be sponsoring an airline ticket to Tobago so that you can have an assessment with Dr. Verne Alleyne. That will be sponsored by my clinic. So listen to me. You're getting to go to Tobago, plus you're getting to see Verne. So I think this might be the best gift that I should really give myself. Eh? So I might join you to go to Tobago. So I'm gonna do that. I'm gonna do that picking of that name for those who asked questions live. Tonight on both my feeds, I'm gonna pick that, and you'll get the name of that winner, if not tomorrow after. And I'm taking a bold-faced view, and I'm adding a sing to that list because Oma has been one of the viewers who has been here consistently every show, Vern. So I want to
Wow.
say thank you to all the viewers. I want to say thank you to you again. I'm seeing comments. Thank you so much, Dr. Alleyne. I'm putting some of them on the screen. Thank you, Dr. Alleyne. Thank you so much, Dr. Alleyne. She has taught me a lot, and you have. And we are grateful for your expertise.
Thank you.
So, folks, it has been a tremendous pleasure to have all of you here for in the course with us this evening, for being with us to learn that yes, we can live well with diabetes, and for us to take control and take the necessary steps for us to live well, to live better. Feel free. These feeds would be on my Facebook pages. They would also be on my YouTube channel. If you have not yet subscribed, subscribe now to my YouTube channel, Back in Motion Physical Therapy Services. Send your emails so that we can answer your questions during this month, and so that you have this information for life. So again, it is my pleasure to have had Dr. Alleyne, and we thank her again. And we look forward to all of you here for our final installment of this show for our first season, Living Well with Diabetes, on Thursday, where we are blessed to have the president of the Diabetes Association of Trinidad and Tobago, Andrew Danu, with us, who will be sharing not only what that the Diabetes Association is about, but will be sharing the expansive amount of work that they continue to do for the people of Trinidad and Tobago and the wider Caribbean, and to let you know how you can become involved. So thank you so much for being with us on Real Time with Dr. Stacy, and we will see you again on Thursday right here at 6:30 p.m. Thank you so much for staying the course. Love you, and we will see you soon. Bye.
Bye.